Pneumothorax is one of those diseases where not only is it difficult to diagnose, but it also has variable treatment options based upon what kind of pneumothorax you're dealing with. That can obviously get a little confusing, but stick around. My name is Maruf, and in this video, we'll go over pneumothorax exactly the way you should approach it on the boards. Let's dive right into it. A pneumothorax is ultimately a disease of the pleural sac. Remember that the pleural sac wraps around each of the lungs and plays two major roles. One is to keep the lungs nice and lubricated and protected as it expands against your pokey ribs, and the other is to keep the lungs nice and inflated because of this strong negative pressure system within it that basically acts like a vacuum to keep the lungs open. In a pneumothorax, you essentially destroy that vacuum system within the chest by allowing air to get into that pleural sac. Now, this now replaces that negative pressure system that once was pulling the lungs open with a positive pressure system that now instead pushes the lungs closed. This can lead to immediate symptoms of shortness of breath and chest pain that's usually going to be described as pleuritic or worse with deep breaths because of that irritation of that pleural membrane. Now, this buildup of air in just one side of the pleural sac is also going to lead to a very iconic presentation of a pneumothorax, and that is hyperresonance to that affected side when you percuss it. Now, the air within the pleural sac also makes it very difficult to hear lung sounds on that side as well, between the lungs barely moving air and the air in the pleural sac essentially muffling all the lung noises. So decreased breath sounds to that affected side is another common feature of pneumothorax. Pretty much a good rule of thumb is if you have a patient that has sudden onset of pleuritic chest pain or shortness of breath and one-sided hyperresonance or decreased breath sounds, then this is a pneumothorax until proven otherwise. Here, the next step will almost always be to order a chest x-ray to confirm the diagnosis, assuming your patient is stable. We're going to talk in a second about how unstable patients are going to go right to treatment. But for now, assume that we're dealing with stable patients, in which case a chest x-ray is going to be your next best step. On the chest x-ray, you should see a characteristic visceral pleural line, which indicates the lung tissue that has separated itself from that outer pleural lining. Now, you'll also see absent lung markings distal to that line, since air has taken over the space and lung markings have all been basically pushed inward. If you see this combination of findings on chest x-ray, then you have officially confirmed a pneumothorax. Now, sometimes you might instead see something called a deep sulcus sign, where if you perform an x-ray on a patient who's supine, then you'll notice that the costophrenic angle appears to go down much further on that affected side since it's full of air within that pleural sac. In either of these cases, once you've confirmed a pneumothorax by x-ray, the next step is going to be determined by the type of pneumothorax you're dealing with. So we do have to do a quick dive on some important classifications of pneumothorax, but we'll get right back to management. Now, technically, there are 5 major classifications of patients that can experience a pneumothorax, and it is very important that you can identify these groupings because it will determine the next step in the patient's management. So the first classification is going to be a primary pneumothorax, where you essentially have a patient that has no lung disease that randomly develops a pneumothorax. Often these patients are tall and skinny and smoke, each of which are risk factors for chronic irritation of that pleural sac and eventual formation of lung blebs that can rupture. So if you have a patient that falls under the classification of a primary pneumothorax, in other words, they have no underlying lung disease, then their primary management will vary based upon the severity of the patient's symptoms. So if the patient has mild symptoms, no abnormal vital signs, then this patient can be managed with supplemental oxygen as their treatment of choice. Now, the air within the pleural sac is technically mostly nitrogen, just like the air in our environment. When you provide high concentrations of oxygen in the lungs, the nitrogen air in the pleural sac naturally diffuses back into the lungs, resolving that pneumothorax. Now, if instead of mild symptoms, your patient has more distressful symptoms or they have abnormal vital signs like hypoxia, then these patients should be managed with a thoracostomy as their next step. In a thoracostomy, you essentially place a tube or a catheter into the pleural sac and suction out all that air. The next classification is secondary pneumothorax, where you have a patient that does have an underlying lung disease, the most common of which is going to be COPD. Now, COPD patients suffer from chronic obstruction of their airways, which in turn can lead to difficulty with blowing air out. So these patients will develop a lot of hyperinflation and high pressure in their lungs, and this allows for blebs and micro ruptures of that pleural sac to occur. When these patients do develop a pneumothorax, they can get pretty sick because they already have such low lung reserve. For that reason, all these patients require more aggressive management, and by default, all these guys get chest tubes to drain that pleural air. Now, rarely a patient might develop a pneumothorax as a complication of a medical procedure, like for example, a subclavian central line placement or a thoracentesis. This is defined as an iatrogenic pneumothorax, and the management is ultimately similar to that of spontaneous pneumothoraces that we just talked about. If the patient has no lung disease history and their symptoms are mild, then you can just give them supplemental oxygen and observe the patient. However, if that patient has more significant symptoms, or if they have any lung disease history like COPD, then they by default have to get a chest tube placement as their primary management. Now, some patients will develop a pneumothorax as a consequence of a fall or some other injury to the chest wall. We call that a traumatic pneumothorax. Now, these patients are inherently high risk and they can rapidly decompensate. So for that reason, all traumatic pneumothoraces should be managed with the placement of a chest tube similar to secondary pneumothoraces. The last classification is a tension pneumothorax, where the patient develops enough air leak and pressure buildup within that pleural space that it starts to compress against the other structures within that chest cavity, most notably the weak-walled superior and inferior vena cava. By compressing the crud out of these vessels, the amount of blood that can actually return to the heart is going to be greatly reduced, leading to significant hypotension and jugular venous distension. Now, you might even see the trachea shift to the opposite side of the pneumothorax if there's enough pressure there, but this is actually a pretty rare finding. So if you see a patient with sudden pleuritic chest pain and a unilateral hyperresonance, and they have signs of hypotension or JVD, then this is a tension pneumothorax until proven otherwise. In these patients, rapid treatment is much more important than performing an X-ray. So you will not choose X-ray as the next step in these patients. Instead, you should be performing a rapid needle decompression at the second intercostal space mid-clavicular line. This will help to temporize the patients until you can actually put a chest tube in as their definitive management. So to summarize, once you diagnose a pneumothorax on chest X-ray, you're pretty much choosing chest tube placement as your default answer for a majority of these patients. However, if your patient is unstable with hypotension, then this is a tension pneumothorax and you have to perform needle decompression first, and then you can place a chest tube afterwards. Meanwhile, if your patient has no lung history, spontaneously develops a pneumothorax, and has very mild symptoms, in other words, a patient with a primary pneumothorax with mild symptoms, then they can just get supplemental oxygen and they can avoid getting that chest tube. Everyone else gets a chest tube first. Now, we've talked a lot about chest tubes. I do want to just make a quick note here that when you are placing a chest tube, the safest location is going to be at either the fourth or fifth intercostal space at either the anterior or the mid-axillary line. Those tend to be the most safest locations that you can avoid injuring structures like the heart or the diaphragm, so very important that you keep those locations in mind. The other thing, when you're inserting the chest tube, you always want to insert the tube above the rib. All the neurovascular bundles are right at the bottom of the rib, so when you're inserting that chest tube, you want to make sure you avoid hitting that structure, and the best way to do so, make sure that the tube is always right above the rib when you're inserting it. So that just about wraps up pneumothorax in a nutshell. If you found this video helpful, please make sure you like and subscribe so that we can keep this channel growing and helping other students like yourself. Otherwise, make sure you look out for the next video in the chest pain series where we talk about a popular topic, pneumonia. I'll see you there.